Well, thank you for that nice introduction and also for the invitation to participate in this conference. My interpretation of the thrust of Frontiers in Academic Pathology, Dermatopathology session was to really update you on exciting advances in dermatopathology that made it easier for us to understand pathogenesis and to manage complex disease. The charge, or the way I interpreted my charge, was almost the opposite of that. Really, what's happened in the past 30 to 40 years that I've been involved in dermatology to compromise communication between dermatologists and dermatopathologists such that it creates problems in patient evaluation and patient treatment. So when I was a resident 40 years ago, almost all biopsy specimens were submitted to dermatopathologists by dermatologists. And dermatologists, hopefully then and now, had a good understanding of the importance of educating the dermatopathologist as to what the patient's clinical situation was and what their therapeutic state was. Also, they understood that there was an importance of integrating the clinical findings and selecting the 3 or 4 millimeter piece of an entire eruption that they would submit to the dermatopathologist to give them the best chance to be helpful. Over the last 40 years, more than 50% of specimens are actually submitted by non-dermatologists, and so the quality of the clinical information submitted is deteriorated. And also, the likelihood that the biopsy specimen is obtained from a lesion that's either too old or too altered by therapy, systemic corticosteroids certainly are going to eliminate eosinophils very quickly, almost by opening the bottle, and also have an effect on neutrophils. Topical clobetasol is certainly going to influence the cells going from the dermis up into the epidermis. And also, when the report comes back, in the past there was more likelihood that there would be more words describing changes in the stratum corneum and in the epidermis and in the dermis. But what's happened is phone calls. Phone calls are the kiss of death in medical derm and also in, I imagine, in dermatopathology if they're not educated calls, which means that the words are not understood. And so there's been increasing pressure to put more clinical interpretation sometimes than even is allowed. So if you have a classic situation where you're trying to distinguish a lesion of psoriasis from a lesion of eczema, which classically, if you have a tiny papule with what the British would call a virginal evolving plaque with scale, you'll see the end result of all the immune processes that have been discussed, which are neutrophils going up into the epidermis and all of the other changes that we learn. And with eczematous eruptions, there will be lymphocytes and there'll be classic changes that we've learned. But when you have a plaque that's had a class 1 steroid applied for several weeks and it's an eczematized or impetiginized psoriasiform plaque or a lichenified eczematous patch, there certainly can be overlapping findings, and this causes confusion. This confusion is magnified. My practice has always been focused on patients with adult and pediatric patients with complex medical dermatology problems. And I'd say that probably as many as 50 to 60% of the complex referrals, we're excluding now delusions of parasitosis and those kinds of referrals from my practice, would be clinical pathologic discrepancy. And this is often really resolvable by a better communication and selection of lesions. So this is a patient with a morbilliform eruption. The clinician, when confronted with a morbilliform eruption that is potentially, let's say, due to a drug, the patients with drug eruptions often have lesions that are dermal-based lesions that can range from areas that might be morbilliform erythemas to urticarial lesions to lesions that might almost be evolving towards urticarial lesions, which are lesions when circled that last more than 24 hours. The patient, if they have DRESS, or better designation now I think is DIS, so instead of drug reactions, I don't like putting pathology terms in the clinical designation because once the eosinophils are gone, is it DRESS or is it not DRESS? So DIS, drug-induced hypersensitivity reaction, is something that we like help with sometimes. And really what we give the pathologist is going to be very much dictate what we get back. I'm just going to go through a number of these to talk about clinical pathologic issues. Bernie Ackerman, with annular erythemas, talked about how there were two types. There was a dermal type and a superficial type. Well, I would argue, despite my respect for Bernie, the late Bernie Ackerman, if you biopsy the trailing rim of an annular erythema, you're going to get superficial inflammation. And if you biopsy the advancing rim, the scaly part, if you biopsy the more urticarial part, you're going to get the dermal reaction. That's true with so many bright red rashes in the skin. You really have to realize that lesions have lifespans, and that you can dictate very much what reports you get back based on what you biopsy. Another important point, why biopsy? Common question I get from residents. This is a classic example of this condition. Why should I biopsy? Why should I biopsy a discoid lesion of lupus? Why should I biopsy classic lichen planopilaris on the scalp? Well, the reason is, as a clinician, you're going to institute a systemic therapy, and the patient's managed by a team of physicians who want to stop your therapy. They're not familiar with your diagnosis, and they're uncomfortable with your treatment. They're assuming that the methotrexate you're giving 4 tablets a week has the package insert of 20 tablets a day chemotherapy. So when the patient has a bronchitis and they go into the emergency room, they're going to tell the patient that they're going to open up. This actually happened to me, a PDR, and even though the patient had had 2 doses of 2 tablets, 5 milligrams a week twice, that they actually had pulmonary toxicity from their methotrexate. So I think knitting together a tight clinical pathologic diagnosis package at baseline is critically important. I've had patients in the winter who've had lesions that look just like this, that actually on histology were classic subacute cutaneous lupus. And then the patient takes a trip down to Florida or something like that, and they come back and it's absolutely obvious that you missed their subacute cutaneous lupus. Urticarial lesions. I personally believe that that it's critical that we circle lesions of urticaria before biopsy, because I think that there are instances, and Desmond alluded to this, where patients with classic acute urticaria from strawberries might have so many neutrophils in the biopsy that you can almost perceive that there's some leukocytoclasia there. By the same token, patients with true urticarial vasculitis, if you biopsy a lesion that's not at the exact right stage between those 24 to 48 hours when you really see leukocytoclastic vasculitis with fibrinoid necrosis, you might have a misinterpretation again. And obviously, if the patient's on therapy like prednisone, you definitely will have a misinterpretation. So I would propose that a lesion that lasts less than 24 hours is urticaria. A lesion that lasts more than 24 hours by definition really isn't urticaria. It should be assessed. Is this an urticarial lesion of Bullis pemphigoid? Is this a patient with urticarial vasculitis? I'm talking about the clinical differential, and the pathologist can really help you tremendously here. I'm going to move on to this spectrum of disease. You know, Desmond was very kind in calling the Bologna book the Jorizzo book, but it's definitely not. Jean Bologna is 100% the driver of that textbook. I got to hang around for all these editions. But the first edition, I was in charge of editing chapters that related to drug eruptions, erythema multiforme, and toxic epidermal necrolysis, and Stevens-Johnson. And I have to say I really got it wrong, because the 3 consecutive chapters all interpreted the difference between erythema multiforme and toxic epidermal necrolysis differently. And the problem is, histologically, all 3 of these settings can have lesions that are classic for erythema multiforme. And by the same token, if you have a patient with Stevens-Johnson syndrome who's even the tiniest little patch of Nikolsky positive change, that's going to look like toxic epidermal necrolysis. So again, this situation illustrates the critical importance of clinical pathologic correlation, and our colleagues outside of dermatology who are co-managing these patients are completely confused by this. So if the pathology report says erythema multiforme, and the patient really has Stevens-Johnson syndrome or has toxic epidermal necrolysis, and you happen to biopsy that one little speck of an area that had a targetoid lesion because you didn't want the epidermis to be completely peeled off, you're going to get a report that says erythema multiforme. And then if they read a later edition of Bologna, they're going to see that, mostly driven by Europeans, the concept is that erythema multiforme is a condition with perfect target lesions and limited mucosal involvement. The erythema multiforme minor would be patients who have little to no mucosal involvement in systemic signs and symptoms, with major would have more systemic signs and symptoms, all within the category of erythema multiforme. And then you would have Stevens-Johnson toxic epidermal necrolysis, and that entity would have a lot more mucosal involvement and systemic features, and probably an evolving spectrum or extent of disease body surface area with Nikolsky positive change. So here are some classic targets. You know, what part do you biopsy? You're going to get a little different change if you biopsy the middle and the top falls off, you know, than you're going to get if you biopsy the edge. So evolving from the kind of lesions that could occur in somebody on a recurrent basis every time they get herpes simplex to the more atypical, and then you see here the atypical kind of target lesions, the more dramatic mucositis. In the first edition, actually the group in Denver, in Colorado, who wrote that chapter really perceived erythema multiforme. They used erythema multiforme major more as a synonym for this, which is not the current usage. A lot of mucosal involvement and mucosal biopsies. The areas where we have the biggest problem with clinical pathologic correlation is when we don't do the biopsy. So children, faces, genitalia are classic places with tremendous potential for error. The patient who actually has pemphigus and is thought to have lichen planus. The patient, and of course the management's completely different. So I think, again, we have to discipline ourselves, and if, as always in our practice, if we're not comfortable with a certain practice, we need to involve colleagues to help us. So I actually have gone to the point in little tiny ones who needed more complex biopsies and evaluations to getting help, or patients with lesions in their oropharynx and getting colleagues. My experience has been, if you have somebody who's an oral medicine specialist who's really good at doing it, you're more likely to have the processing of the obtaining of you might have the correct specimen obtained and processed. So here are the more extreme TEN. Once you go down into the fat, there's a tremendous, we have, I always have thought it's interesting. In the Bologna book, in the index, there are probably 350 diseases you could see if you do adult and pediatric dermatology, and you do patients with, you do dermatologic oncology, as well as see inflammatory diseases and maybe some cosmetic stuff. In rheumatology and cardiology, there are 15 or 20 main diseases. You have to think, if you took that synovium out, there's got to be more stuff in there, And the skin, if we could only look at it, inside the body, probably lichen planus and eczema and psoriasis would be hard to tell apart. So in the epidermis, there's a tighter structure. In the dermis, there's a tighter structure. And we have this beautiful array of dermatoses. But once you go down to the loose subcutaneous tissue, it kind of falls apart. We basically have lobular paniculitis, and then there are a few septal disorders, and then there's lobular paniculitis with septal leukocytoclastic vasculitis. So you can find very specific things, infections and calcification, et cetera, in the fat that'll help you. But almost every patient that looks like this patient is sent to me as erythema nodosum. And almost always, when I biopsy it, it's a lobular paniculitis. The other thing that I think we clinicians sometimes mistake is that if you have a septal paniculitis, i.e. erythema nodosum, it can't suppurate. It's impossible. You can't have degenerated liquid fat and other material coming up to the surface if the inflammation doesn't affect the lobule. It's not possible. So you sometimes have the ability to subclassify lobular paniculitis, but often you really don't. So we're forced to, do the best we can to exclude the diseases that we can, and then we have to proceed with, management as best we can. Let's see, where are we here? What did I do? Oh, okay, now we're going into things. What about, I can tell you, I was on the board of, for 15 years, an international committee on Behçet's disease, and it was really kind of an enlightening experience because there were ophthalmologists and neurologists and dermatologists, and when people get together, they feel a need to reclassify things. I thought that the people that got together with cicatricial pemphigoid and changed the name to mucosal pemphigoid were a group of GYN physicians and dermatologists, and it didn't make a lot of sense to me on a disease where a quarter of the patients have non-mucosal lesions and the hallmark is scarring. I think in Behçet's disease, really, if you have a child with canker sores, acne, and anterior uveitis, they have Behçet's disease. So sometimes this is a classic example of garbage in and garbage out. Well, I'm going to tell you, I'm using this for a reason. I had a patient with true Behçet's disease, and we can leave it at this, who had classic biopsy. I think it's very difficult for me to separate oral aphthy from genital aphthy. I mean, oral aphthy are easy to separate from herpes. Genital aphthy are very hard to separate from herpes. So this patient had oral aphthy, genital aphthy, posterior uveitis, cutaneous pustular lesions with neutrophilic vascular reaction. And they had a genital pyoderma gangrenosum-like lesion. So we were doing more and more anti-inflammatory therapy. And when there was a lack of response, we finally did another biopsy, and the patient had granulomatous herpes. So you have to remember that in an immunosuppressed host in particular, herpetic lesions do not look classic, and they can last for a very, very long time. And it makes the point that just because a biopsy's been done, I mean, there are countless instances where people had classic pyoderma gangrenosum and they had 3 or 4 ulcers, and then in the middle of all that, they got a squamous cell that looked like a PG lesion. We reported a patient once that had pyoderma gangrenosum, we thought. We biopsied to exclude, as a diagnosis of exclusion, AFB fungus, routine bacteria. The patient got worse and worse as we added more immunomodulating agents. We biopsied again, negative, nothing showed up. More treatment, worsening. On the 3rd biopsy, we found the sporotrichosis. And when the article was submitted, a pathologist wanted to review the original slides, and they could not find sporo. I think we've got to evolve a panel for those infectious granulomas that have either atypical AFB or sporo that we just can't find, because the clinician is stuck because the ID people will not help you unless you have an organism. That's the reality of modern practice, or at least ours won't. Okay, moving on. I don't think there's much to say pathologically here. Bullis Impetigo is interesting in that Bullis and non-Bullis Impetigo for pediatricians is an everyday phenomenon. I think it's relatively rare for dermatologists. We see a lot of impetigenized dermatoses, but not a lot of primary impetigo. So I think patients often come to me with antibiotic after antibiotic after antibiotic, and I think a common clinical mistake is to take the swab as being something that has to be pursued. So babies tend to, I mean, it's a bad thought, but they tend to have fecal organisms all over their eczematous eruptions. And so it's very important to distinguish between tissue infection and surface organisms, and I think in leg ulcers, even worse. It's really a soup that can have all types of fungi and bacteria, and those should not be chased. I think biopsy specimens can be very useful in borders of ulcerative lesions if the organisms are deep. And that's true in immunosuppressed patients. I know you're going to hear about that from others today. Now, I had a patient, and probably we need to have the panel discussion, so I'm going to stop after this one, but the autoimmune bullous diseases. I almost like to talk about, well, here's one. Let me, regardless of what the cover slide says, I want to make the point on this one. Twice a year, I have a patient with almost anasarca forget about the slide that said pemphigus. I want to make a different point. And the referring diagnosis says that the routine histology diagnosed bullous pemphigoid, which was confirmed on direct immunofluorescence. And you look, and it really looks like stasis bully. And it's gotten worse as the patient was put on 60 and 70 and more prednisone. And the edema gets worse and worse. And you look at the immunofluorescence, and it actually talks about fibrin and some patchy, obviously not from here, but or Cornell, and shows some patchy, or Wake for that matter, patchy complement deposition. And so I think it's really important. And this is another thing that residents are going to say, why do we really have to do all this confirmation at baseline? You have to do it because if not, you're going to get messed up with some of these patients. You're going to launch on treatment courses without precise diagnosis. And we now have the capability of getting not only direct and indirect immunofluorescence, routine histology, but also ELISA confirmation. So I think that really puts together and knits a tight package. I'll never forget a referral call from a family physician. I did a biopsy from an intern, and the intern's biopsy showed Haley disease. And something about that situation made me ask a little more. It was a little patch on the chest. And I said, well, let me see the patient. And I looked, and the patient had desquamative gingivitis. And I said, well, what's this? And they said, well, my oral medicine specialist told me that this was cicatricial pemphigoid. And I said, well, were biopsies done? No. So the thing is, this patient had pemphigus. I mean, this is a disease that before treatment had a 2% 5-year survival before prednisone, let alone the modern advances with Rituxan and Cellcept, et cetera. So the theme then, and we could go through all the diseases, with bullous pemphigoid, if you biopsy a lesion that has no erythema at the base, porphyria is going to be in the differential. If you biopsy a lesion that has a dramatic urticarial base, it may even look a little bit like a bullous leukocytoclastic vasculitis, whereas if you give the pathology specimen that's just right and the epidermis stays on and you get your immunofluorescence not from the blister where the immunoreactants are chewed up, but from the edge, then you have really the best opportunity. And of course, it doesn't work as well when the patient's had 3 weeks of 60 milligrams of prednisone. So I'm going to stop there and thank everyone for their kind invitation.